good.
All right. Good morning, everyone. Let's call the Human Resource Committee meeting to order. Okay. We have no citizens wishing to address the committee. So our our first action item will be our minutes. Okay. All right. All those in favor signify by saying aye. Aye. Okay. Okay. The next item that we have on the agenda is Bill will come up and discuss the annual incentive plan for fiscal year 19.
Good afternoon.
Hello.
I believe in your mail out, we have provided proposed goals for the fiscal year 2019 annual incentive plan. As you might recall, this is a plan that provides a potential payout based on an operating margin trigger of break even to all of the organization. We've had a discussion with the chairman, Mr. Bowes, and we're trying our best to eliminate, if not at least mitigate, some redundancy in some of our goals and metrics. And what you will see under quality is just a shift, if you will, from a particular quality metric like sepsis, which is what we're tracking this year, both abdominal hysterectomy and colon SSIs, to a more global composite. And it's called PSI 90. It's a nationally recognized standard or benchmark or measure, if you will. Okay. That includes 10 metrics that really cause harm to patients, to hospitalized patients. And it's based on the volume of occurrences and the acuity of the patients that a hospital or an organization is treating. So it's really an observed, expected type of metric. Each of the 10 measures, and an example of those, I think I had those in front of me, things like pressure ulcer rates, pneumothorax rates, post-operative hip fracture rates, things like that. Each one of those 10 have a different weight depending on the severity to the patient itself and depending on the volume of those instances in the past. So under an observed expected type of rate, 1 is normal. You don't have any more than the next organization would have. Anything above 1, you probably have some opportunities to improve. And then you drill down and figure out which one of those 10 is really above the expected rate. So what you're seeing there in that recommendation is we think we'll end the year, this month, at 1.1. So somewhere in those 10 metrics, we have significant opportunity to improve and bring that down. We've recommended that we establish a target of 1, which is normal, and a stretch target of 0.88. And what that represents is a 1 standard deviation from target. So 1 standard deviation for threshold is 1.2, and a standard deviation from target to stretch is 0.88. Any questions before I move on in terms of quality? We will be sure and make that available to everyone on the committee. Okay? It's, we'll do that today, Dr. Weber.
I'm sorry, I thought I had one in my book. But Chuck, it kind of rolled up all of the ones that we was looking at individual. They just put them on a all together 10, and it was 5 or 6 of them, at least 7 of them, we were already monitoring, but we were just pulling a couple of them off. But it's something new, and I'll get that to everybody, because it is different, but it allows us to look at several things. And if one improved, doesn't mean that all your scores, the overall score is gonna go up, because different one is weighted a little bit heavier. And so it kind of makes a little sense for us to kind of look at it a little bit more. But it was new to me, and so I had a little bit more information, but I think it is something that will give us some information, but it will tie into your quality committee. Okay?
Well, it's an indicator that allows us to drill down to even the provider level, right? Organizationally, nationally, state, regional, and even at the provider level.
Okay.
The next recommendation is around service. And what you're seeing for fiscal year 19, we propose is to continue to focus on HCAPS, which is the patient perception of care, inpatient perception of care, and the patient experience overall in our clinics. We have focused on a percentile ranking for a long, long while. And we have reached that point, I think organizationally, that we have appeared to be stabilizing that overall perception of care from a percentile ranking perspective. We really want to focus on the dimensions, all of the dimensions within the survey itself. And this is a proposal that is really, by and large, based on, from an NRC picker's perspective, the average improvement rate of each dimension nationally. And that's why we're not recommending necessarily what that rate is today, but for instance, a particular dimension might move nationally 0.6. That everybody that's making improvements, it's a 0.6 improvement over the previous year. We're saying that if we have 3 dimensions that improve, at least one of those improves 0.6 or greater, we'll count it. If it doesn't, if that one dimension doesn't improve 0.6, we won't count it as improvement either. Now, every one of those have different rates of improvement. And that's what we're saying. These recommendations of 3 improvements, 3 dimensions that are improved, 6 dimensions that are improved, 8 dimensions that are improved, are based on the national rate of improvement for each dimension. So if we improve 8, but none of those equals the national rate of improvement, 0. Does that make sense? Yeah. And we won't know that until probably the next time the HR committee meets. We will have more information on how we ended the year and what the national rate of improvement is for each one of those questions.
And it might help if we share with them the information about those dimensions. It makes sense. It's 10 of those questions that we are looking at.
Yeah, it's the standard HCAPS inpatient questionnaire, but they're based on dimensions. And there's multiple questions within those dimensions. And we'll get that to you as well. Along with the PSI 90, we'll pass out that HCAP score, that survey, and let you see everything that's contained in there. That make sense?
Well, it does from Laura's presentations, the quality stance has been, how do you know you're delivering quality care? And
right.
The answer has always been, it's based on the score from the, whatever cap it is, I forget.
Right.
HCAPS.
HCAPS.
Right.
Mm-hmm.
And when we report that and compare ourselves on a percentile ranking, we've been focused on one dimension, the overall rating.
Right.
This allows us to focus on all 10, not just the overall. So these are indicators that are leading indicators that do affect the overall rating, but you know, we kind of plateaued at the 75th percentile, and we're 72nd percentile, 70, Laura's coming up, that's great.
He does not want you to drop off a piece of paper.
No.
He wants you to sit down. When he said you were coming up, that was not special delivery.
These are the dimensions that you asked for, and Laura can share those with you. I don't have those in front of me.
Sure. So the dimensions that are measured within HCAHPS, one of those dimensions is the overall rating, which is what you have seen on the quality board every time we do that. Additionally, there's a care transitions dimension, which allows us to know how well are we transitioning our patients from the hospital to their point of care after. Cleanliness and quietness, which covers environmental services, obviously, and others. Communication about medication. So how well are we explaining the medication that's been provided? Communication about pain management and how we're doing with that. Communication with doctors and communication with nurses. Discharge information, responsiveness, and would recommend the hospital. So there's 10 dimensions in there. And the reason we're recommending this is because it allows us to actually cover the house. So the overall rating's a little bit hard for people to say, gosh, here's how I can impact it. But when you look at one of the dimensions being cleanliness, EVS now has a direct ownership to it, if that makes sense. So.
And these dimensions haven't changed.
Right.
They've been the same. We just haven't necessarily been transparent about those to the HR committee, the quality committee.
The result, when you say three of the 10
3 of the 10
to improve?
have to exceed the national rate of improvement, whatever that may be for a given dimension.
And the other 7 could,
Well, we could either take a step back, stay the same.
okay,
We're looking for improvement, right?
okay, I just wanted,
Yeah,
So
which,
they may improve, so they may improve, but if they don't improve at the average rate nationally, then we would not count those. So we may see a 0.4 improvement where the national rate of improvement for CMS is 0.7, and we would not count that on there, even though we're getting better.
but Chuck, I think overall, we are trying to break it down, so when you have the overall, everybody knows the dimensions, but now you can focus on one of those. Nursing is gonna focus on communicating with that. Environmental services is gonna do cleanliness, and so it will give you an opportunity for different ones to focus, and we believe we can move those scores, because we've been right there, and so we had to change, because overall, we are not moving. So we've got to start moving some of them to get the overall. So it's a change for us, but I think it's one that we can focus on a little bit more.
I think what it does is it helps to establish ownership at a greater level. Because if you have just a percentage, it's hard to know,
Right.
how can I own this? Because all of us could be walking down the hallway and pick up a piece of paper.
Right.
And pick up a cup. I mean, we can all contribute at some level. So our employees now say, I'm invested not in just that overall score, but I can actually target each of the
right.
next.
That's it. Okay.
I've got a question, and excuse me for being late. I think the new weights and adding the 10 scores is a good plan. My question goes to, it seems like we're always evaluating and changing the targets, and it's very difficult to go back to the previous year and say, yeah, we did approve, because, well, this incentive plan has different stuff than the last year's plan had. And I understand healthcare is dynamic and a lot changes in a year and whatever else, but it seems really hard to compare to last year when the plan changes every year.
Laura, but we will be able to compare last year, because your overall scores will still be there.
Absolutely.
So
We'll always compare the percentile ranking. Yeah.
And we've actually used the same methodology
Right.
since I've been here, which is the last 3 years. The problem is, when you hit the top quartile, the difference in 75th percentile and 100th percentile is so small that it gets very challenging to say, yeah, we're making improvements where we need to. So what we're really looking for is, how do we move the needle beyond the 75th percentile-ish?
Driving down further, trying to get the overall.
You got it. And so, to your point, Dr. Potowitz, this is about creating ownership across the network So everyone can see, this is what I need to do in order to impact our patient's experience.
But we still will be able to look at
Correct.
Oh, absolutely.
apples to apples, because we'll still have that overall.
That's correct.
Every time quality meets, we will have that visibility into the percentile ranking of our HCAPs. Yeah,
Okay,
in addition to this.
all right.
Okay?
Any other questions on that?
You might want to stay for you know, historically, and I think I understand this. Laura probably has a better feel of it than I do, but historically, we've looked at CG caps, which is the rating of our providers in the clinics. And it seems like I kind of give the an analogy of we've hit this plateau in the inpatient setting of the 75th percentile, somewhere around there. We continue to kind of bump the 30th percentile in the clinics. That's not acceptable. And it's really focused on the overall rating of the provider in the clinics. And more organizations that have clinics and use CG caps are moving away from CG caps. It's a very onerous survey. It takes time. The call is well after the clinic visit, or the survey itself arrives well after the clinic visit. And most organizations want better information sooner, right? So we're kind of joining that movement, if you will, and we're proposing that we do a survey ourselves through Picker, call the patient the following day from the visit, use 10 questions. And this is the same methodology. We're going to focus on those improvements in those 10 questions. Now, we don't have a national rate of improvement because there's not enough data to support that. But we're recommending 0.3. For every one of those 10 questions, we're recommending that each of our questions has to improve 0.3 over the previous year. Otherwise, we don't score it as improvement. So 3 is threshold, 6 is target, and stretch is 8. Does that make sense? And we're looking at everything beyond primary care as well. CG caps, we kind of focused last year on just primary care, but we need to know how the specialists are performing. And that's what this recommended metric is, specialty care and women's health. What did I leave out?
What questions do you have? Let me start there.
I like this new paradigm.
Yeah.
And it really is quite nice. It makes it more real, I think, for all of our employees to be able to say, what are we really looking at? And then I like the timing, because one of the frustrations is that we're all evolving our practices in the clinics all the time. So we don't know if we're 2 or 3 months out,
Correct.
what that comment really means in terms of the daily practice today, because we've already made changes. And so do we
correct.
discount it or do we count it?
That's correct.
We can make improvements.
Almost in real time.
Almost
Yes.
in real time.
It is. Yeah, that's actually a really important point. So the new survey tool comes out the day after the clinic visit. Whereas to Bill's point, when you utilize strictly CG caps, it could be several weeks after the visit. And if they've been to several visits during that time, that can get, mixed up too in the patient's mind. And this allows us to receive about somewhere close to 100,000 surveys back from our patients in the clinics, as opposed to less than 10,000. So that's what we're on track for this year. So we also have some flexibility with the questions. So to your point, if we say we're going to make a change, we can actually change the questions on the surveys in order to be able to move them if we chose to, or add them. We don't want to change the 10 that are on our AIP, but we can add questions to that to double check and test different things. So it really is a real-time improvement process that we now have access to. And the reason we have access to it is because CMS has put CG caps on hold for being a publicly reported metric. And so we'll still measure that. So again, to your point, we'll still have a statistically significant baseline of CG cap surveys, but the majority of our surveys would come in that more real-time fashion.
Any other questions on that? Okay.
That's a big stretch there.
Big stretch. it's a big stretch.
Is it,
It is.
is it feasible?
It is going to take a lot of work. When Bill mentions 0.3, that doesn't sound like a huge improvement, but when you're looking at a big database, 0.3 is really hard to move the needle. So, it's,
My only concern, I mean, we all know it, but my concern is that, is it reasonable? Because when you try to push for quality, sometimes the other
Well,
side
here's the
may-
point of reference that we're trying to use on every one of these goals and the performance levels, is that 90% of the time, one might be able to hit threshold. 50% of the time, one might be able to hit target. And 10% of the time, one might be able to hit stretch. Now, we're able to interpolate between those segments. So if we fall between target and stretch, there'll be a mathematical interpolation. But that's kind of the premise and the predicate of which this AIP is built.
I learned a new word,
What?
interpolate.
It's a good word.
It's like truthiness.
You guys don't put a lot of stress on your team to get to that
Yeah.
stretch. It is a high rhythm.
I would
Did
say
I
that-
misstate that, Dorothy?
No, you did not misstate that, and I think one of the deals is that we're not saying that you have to move all 10 of them, but of that 10,
Attention, please. Code red, lower level cafeteria. Attention, please. Code red, lower level cafeteria. Attention, please. Code red, lower level cafeteria.
It's the same damn fire.
right, was there earlier. It's- But DT, to follow up with you, is we're not moving all 10 of them. We're saying out of that 10, at least 3, and then target would be 6. And so that gives them some flexibility. And it depends on what our results are, because we might be a little bit higher than that, but we don't, but we'll have to go with that, That's what we're looking at, okay?
Okay, moving down to the people pillar. We are experiencing a little higher turnover than we want, and we've kind of used a national benchmark through the Saratoga organization, and they're saying that organizations our size and with the number of employees that we have, 11.2 seems to be the average of those organizations. I think we're running around 12.4, somewhere in there.
Attention, please. Code red, all clear, lower level cafeteria. Attention, please. Code red, all clear, lower level cafeteria. Attention, please. Code red, all clear, lower level cafeteria.
So, as we normally do, when we have opportunity for improvement, we want to focus on that, and we propose to establish the national benchmark of 11.2 as our target for fiscal year 19. And that we will come back to you, as we will in all other goals and metrics, the next time the HR committee meets in November, based on our year-end performance and propose actual performance levels around these goals for fiscal year 19. But we certainly want to be at least where the national benchmark is, and that's our target for next year. We only have one metric in people, as you might recall, and we'll go over the fiscal year 18 results later on, but that one metric in people is around employee engagement. And we've had that for the last 3 years, as I recall, and we have really done a bang-up job because we're at the top decile. So we don't want to take our eye off the ball. We want to propose that we continue to focus on that. But I think when you, as Laura described, when you get to that top quartile or the top decile, the amount of movement is so infinitesimally small that it's really, really difficult to move that needle. So we want to continue to focus on that as a stretch target, but we might see a little bit of backsliding. That's to be expected according to our vendor that we use for the survey. So we would like to recommend that that stretch target of the top decile be something we focus on from employee engagement, but we'll bring back performance levels at the threshold and target level based on the results of our survey that are concluding this week, and we'll have more information on next month. We have historically not included provider engagement on our people pillar, and we have completed our provider engagement survey last year, and we have just concluded this year's provider engagement survey and recommend that as an organization, we embrace that goal as well. We don't have a lot of data to support a baseline today, but whatever that baseline measure comes in, and we'll report that next month, we'll recommend some performance levels for fiscal year 19 around provider engagement. Any questions on pillar? People. Stewardship, we are suggesting a modified cost per adjusted admission this year versus a cost per adjusted admission. And for those of you who were in finance, Sharon described a situation that we didn't budget certain things in fiscal year 18 around URIP. We didn't budget the revenue, we didn't budget the IGT. So in our discussion with Ms. DeBose last week, we talked about focusing a metric and a goal around things that our managers could influence or control. And if you extract the URIP discussion those numbers, which is around $150 million total, somewhere in there.
That also includes the
Physician reimbursement, yeah.
contracting and claims payment.
If you extract those dollars, those categories, those expenses that really none of our managers can control, this is what you end up focusing on. That's the modified cost per adjusted admission that we're proposing. It's not reasonable in our mind to hold our folks accountable for things that they can't influence, that they can't control. But if you net it out, they can control all of this. So we're recommending that modified approach. The threshold is equal to budget. The target is equal to a $3.2 million improvement over budget. And although the numbers are relatively small, the stretch is a $5 million improvement over budget based on the number of admissions that occur in fiscal year 19. So it's a little different way of looking at the same goal, but I think this is a fair representation of what we would ask our folks to do.
Any questions on that? Because it really makes sense that for the directors who's responsible for staffing, supplies, and for stuff that they order, they take care of that. They really can control that cost. But for the overall cost, we have that in the executive portion. So.
I really like that a lot because it does bring it back to the people that can influence.
Oh, absolutely. Yeah.
Okay, all right.
Population health, we continue to discuss the appropriate goals and the appropriate metrics for this organization around population health. And we will probably continue to discuss that for a long time because population health is one of those things that seems to be defined differently to different people and depends on who you talk to. But we know for certain that we still have opportunity in the specialty care arena, access to specialty care. And this is a continuation of the goal and the metric that we have used in fiscal year 18. And it's around 4 specialties. I think I might have had those. It
was, yeah, it's 4.
It's pulmonary, it's urology, it is, somebody can help me from the back. It's what?
GI,
GI.
In urology.
Okay, so it's those.
It's focused on those 4 because those 4 disciplines have the greatest effect on our geriatric population, which we're trying to establish, right?
Okay.
And we made a lot of improvements. When we began focusing on these 4 disciplines, we realized there was a lot of cleanup that hadn't been done, that needed to be done, and we were able to do that. But it's a composite average of all of these, because some of these queues are fairly long, some of these queues are shorter than the others, but we have moved it from over 100 days to the lower 90s as of this month, I believe.
Yeah.
So whatever we end up fiscal year 18, we would propose metrics the next time this committee met of a certain percentage improvement over baseline for target and a certain percentage improvement over baseline for stretch. So that represents the annual incentive proposal for fiscal year 19, and I'll be happy to entertain questions or dialogue.
I want to thank Bill and Laura and Annika and Dorothy, because that's not an easy task. It's hard. And a lot of those are moving targets. A lot of those are targets as you improve. There's a high level of improvement, and it's challenging. And you want to be realistic, because as Dorothy knows, if you set those goals too far out, they become unattainable and people won't work towards striving for them. If you're too low, then they're too easy to obtain and you haven't moved your organization. So hitting that sweet spot is not easy. And Annika and Laura and the team, and I think Bill and Dorothy, I think y'all did an excellent job, and I appreciate it, and I think the organization will better for it. But it is not an easy task.
No. And
It's a journey.
it's a journey, and who we would like to join us on the journey is Acclaim, and see if they can look at some of the things that we're doing. And, you know, we put our VPs and executive VPs at risk when we don't meet certain deals. But if they do, they're rewarded too. And so Chuck wanted to see if Acclaim could look at something that kind of develop, or look at what they could do to tie
Well, yeah,
some
they
of
have to
that
be
in.
an integral part of this.
Yeah, they do, and we talk about it, but I haven't, I don't know of anything. I saw some criteria, it was going to meetings and certain stuff, so I'm just asking if maybe if Acclaim could look at how, what we're developing here annually, could they look at doing something annually, some kind of program that would, we can't succeed if they're not working with us, so I would like for them and their president to be right up there with Robert and the rest of them that's sitting out there saying we are, you know, we can do this and we can be at risk too, so.
No, I agree with you. 'Cause
Okay.
If a claim does not succeed, the organization will never get any better than we were 10 years ago.
All right.
Okay.
Okay.
Thank you.
All right. So you'll come back and tell us if they, what they are, how they're going, if that's feasible. All right, okay. I'm looking at you now. You'll be up here, huh? Okay. Are there any other questions on this? Because I do want to just thank the team, and Pierre was in there looking at all the stuff and working with us too. So had a good team, a lot of discussion, and so I think they've done a good job at hearing the concerns and moving it forward. All right? So I need a motion to approve this. Okay, Dr. Podrich, and second by DT. All right, all those in favor signify by saying aye.
Aye.
All right, thank you.
Thank y'all very much, and thanks for the efforts of the team. Y'all did a great job.
Are you still up, Bill?
I am. At least looking at the agenda, I am, unless you want to vary from the agenda.
No, I think we can cover this one. This is.
Yeah, this is relatively straightforward. This is our incentive plan for fiscal year 18, and of course, we haven't concluded the fiscal year. The trigger for this plan, as it is for fiscal year 19, is a break-even, a positive break-even, well, a break-even margin, operating margin for the hospital. And for those of you who were in finance at the meeting earlier this morning, we're at that bubble, if you will. It really depends on how the month of September turns out. But for this current year, we focused on surgical site infections under quality, both colon and abdominal hysterectomy. And you can see that the surgical site for colon is at 13, and our threshold was 10, so we're well above the 10, and we're well above where we were in fiscal year 17. And a lot of that is due to how we measure those things. Being a level 1 trauma center and focusing on every single patient encounter is rather difficult, because if you see, as I understand it, and Dr. Weber can either agree or not, but as I understand it, we see a large number of gunshot wounds that come in here, and that's, as I understand it, virtually guaranteed you're going to have some sort of infection from that. And if you look at rates, maybe we fare better. But if you look at people, which I know the intent was to focus on each individual encounter last year, it makes it very difficult. If you eliminate some of the gunshot wounds that come in, maybe we don't have as many surgical colon infections. But that's kind of one of the problems with dealing with that particular indicator at a level 1 trauma center. The other is abdominal hysterectomy, and we currently, I think we're at, what does that say?
Mine says 10, I can see it up here, 10.
Right.
10,
And the threshold for that one was 13. Yeah, there it is. So
under that.
we think we're going to be in the range for that one. Population health, we talked about the specialty care access, and you can see there that we were at 102 days in fiscal year 17, and currently we're at 93.9, and I think that's through the end of last month. So hopefully we'll see some further improvement at the end of September. The other metric that we've been focused on for a number of years is the days to next third new patient appointment in our primary care clinics. And we have struggled with that, as you might recall. This year, we are at 11. 11 of our primary care clinics are able to see new patients within less than 25 days of a call. So that's a tremendous improvement. We think we have basically hardwired that process, and we would recommend, as you had heard earlier, that we not focus on that as a metric for fiscal year 19. Service, again, HCAHPS, the percentile ranking, the overall ranking, if you will. Latest results as of yesterday, we're at the 75th percentile. Target is the 75th percentile with a threshold of 72nd. CG CAHPS focused on just the overall rating of the primary care physician, the 29th percentile. And that's a threshold performance level that we have kind of hovered around for several years. ED CAHPS is measuring the overall experience of our patients in our emergency department. And I am so happy and proud to say that we have been well above the stretch goal for a number of months. And it's just incredible that we're able to achieve that, given the population that we serve, given the environment that we find ourselves in, and the number of patients that are sometimes in the hall and not in the rooms.
And I think, Bill, at that point, it should be noted for board members and anybody watching live streaming that, in all honesty, not bragging on anything we've done, but what that team down in the ED has done is when you put split flow triage into place, we are able so quickly to be able to triage people that we're almost outbesting ourselves, because we do so well now. We have such a reduction in left without being seen. We get people seen instantaneously but the problem is, we don't have enough beds to reduce a 30 to 40 patient boarding problem. And it's a challenge. And then when you put somebody in a bed in a hallway, and although you monitor them, it's extremely tough to get a survey out of them that says, I really appreciated my stay. And it's a hard situation. I will tell you, I've talked to my colleagues in the industry, and boarding is not unique to JPS. It is a challenge in our emergency rooms too. So to have those kind of numbers with the conditions we have, if any of you have walked recently down an RED, you will see that challenge, and it is incredibly tough. And our team is doing an amazing job in a hard circumstance.
Thanks, Robert. Those folks are continually making changes on the fly, whether it's the environment, whether it's the staffing, whether it's the workflow. It's just amazing that the work's being done. So we're recommending that we not focus on that in fiscal year 19, but continue to do the good work that we've historically done. Finance, we have focused on the FTEs per adjusted patient day, and we have done a really good job there this year. It's 5.59, where our stretch was 5.76. And we, this year, continue to focus on reducing our overall cost per adjusted patient admission, although when you include those variables that I just discussed a few moments ago, we're not able to scratch the surface at the threshold level. So we are at 14,928 through August. Human resources, again, we're focused on employee engagement only. We just concluded that survey this week at a 93% participation level of our employees. That is even better than last year. So I think that's pretty good indicator. We shall see.
We need to let y'all know, though, there is a point where we can't grow in that. Statistically, we cannot grow unless, people take the survey 3 or 4 times, which we won't allow. So we are proud of that, and it is exciting because, again, that speaks to the point that you have that first rule of ownership firmly entrenched in the organization, because even when they're frustrated, they're still communicating with us. And that always allows for solutions. Where you have an organization that has gone stale is when you don't return surveys, because then they don't care and they have given up. So this is a very engaged organization, and my thanks to Pia and the team, but to the directors and the managers that work hard in providing fairness in saying, please fill out your survey so we can get your opinion. And I think the other thing, and Dorothy and I talked about this, the thing that has helped with our surveys is when they respond to them and they suggest challenges, a lot of times they're addressed when we can address them. And I think people have said, wow, if I actually respond to this, I can actually see changes at JPS. Now, some of those changes we can invoke, and we tell them that too. But I think that's why you have a higher percentage this year. But I do want to caution y'all, we will hit a breaking point at some point. We can't continue to grow at every year.
So this is an update only. It's not final. And the next time we meet in November, we'll bring the final results and the recommendations for fiscal year 19 performance levels.
Yeah, that was one of the reasons I was very glad to see that they had increased looking at turnover and some other things, because they could not stay there. If you get that high, you not but one way to go.
Right.
Starting to slide back down. So, okay, any questions? All right.
Thank you very much.
Thank you for the update. Okay. Next is Ms. Pia. Good evening.
Good afternoon, everyone. How are you all doing today? Good. Well,
All right.
what I would like to do is provide you with an update on our human resources dashboard relating to turnover. Of course, as Bill just spoke about, turnover is a metric that we truly keep our eyes on. It's something that we want to focus on ensuring that we are attracting, retaining, and developing the correct talent within the organization. So for us, as we communicated on the AIP dashboard, we do benchmark against Saratoga data for turnover. And if you look at this report here and looking at the dashboard, we do benchmark against the total voluntary turnover. If you look here at this piece here, I was hoping that it would circle for me, 11.20. That is our key number that we want to look at for the voluntary turnover. So looking at Q3, which we closed in June, that provides an overview of where we were overall for Q3. A key piece at looking here at this document is when you go down to the actual job classes, it provides the breakout of where we are for each job class with the total voluntary turnover, which is on an annualized basis. So the key number that we do want to look at is right here, which is that 12.21%, and that is going to be the final number that we will be bringing back to the HR committee in November. So
Are you circling those
yeah,
numbers?
I'm trying to erase it. I know.
You need to go to Sharon Clark School,
There we
because
go. Yes, there we go. I took it off. Yeah, there we go. So, yeah, so I'm going to do a check mark instead of a circle. Check mark. There we go. I think that's a lot more better.
There
because
you
I can't
go.
circle.
There you
yeah, So I'm
go.
going to check mark it. So as we look here, the voluntary turnover as we closed the third quarter was 12.21%. Again, benchmarking against Saratoga data, we want to come at that 11.20%. Not doing too bad, but again, since that will be a metric that we will be focusing on for FY19, is putting emphasis on what we truly need to look at for turnover within the organization. Okay. Are there any questions?
What is technical management?
Technical management, those are positions. They are like your project managers. Those are the roles that do not have people reporting into them, but they may have a title such as director or manager, and they're more manager of a process, not people.
Okay.
So that's what we do to separate them out.
Okay. Any other questions on the?
IT's looking pretty good.
Oh.
Because isn't there a fair amount of turnover in IT?
it is. And
Usually?
it is. It is a fair amount of turnover, and IT can be challenging sometimes.
So this is pretty good.
It is.
Right.
It is.
Mm-hmm.
They need a pat on the back.
We will be happy to do that for them.
All right.
Dorothy does that.
Must be IT leadership.
Huh?
Must be the IT leadership.
Well, I think it's I have a feeling that goes into it too. And when we do the total turnover, that's including involuntary and all, that's
That's
everybody is
everything.
included.
Yes, it is.
Yeah. Okay, any other questions on that? Okay,
All right, thank you.
all right. Well, next, we will have our diversity inclusion presentation by Michelle. Michelle, you see how fast they leave you up there by yourself?
Well, good afternoon.
Hello.
I am so excited to share with you an update from Diversity and Inclusion. And this is my first update, so if I look a little nervous, that's why. But I'm excited to speak with you about some really good news that we have for the areas of diversity and inclusion. Today, we really wanted to focus you on updates on where we've been since 2016 in the summit. Many of you know that we did a summit in 2016, and that was a really important event for us where we said, let's look at our current state. Let's see where we are now, and let's look at where we want to go as it relates to engagement of our workforce, as it relates to patient satisfaction and cultural competency. Thank you. Thank you. As it relates to those areas, and then we're going to focus on where we've been and then where we're going. So our agenda today is to look at the updates. We'll talk a little bit about employee education and vendor education, and then we'll focus on our commitment to partnership. And you'll know that diversity and inclusion is partnering with the patient experience group to do great work together. And then what we've been doing in the community. We'll talk about our community and a little bit about business and supplier diversity. But most important, we really want to present today our strategy for moving forward. And we'll do all that in about 15 minutes. How about that?
All right.
All right. Let's take a look at, first thing, let's take a look at the graphic. You'll see before you a graphic that has diversity and inclusion in the center. We place diversity and this inclusion in the center because we believe that diversity and inclusion is at the heart of what we do every day here at JPS. And it touches everything that we do in terms of our community outreach, our partnerships, making sure we have health equity, working together for many dimensions. So it's at the heart of what we do, and it touches every part of that. So a couple things in our presentation you'll see at the top left there. It says we really want to focus on how we support and sustain and engage workforce and in work environment. How do we support that? And we'll tell you that today. How are we restoring about cultural competency in our approach? What are we doing with cultural competency and making sure that our patient population is served best in all areas? And then finally, we'll talk a little bit about how we ensure we use historically underutilized businesses, because we believe that that drives and increases innovation and competition, and it's good for the overall health, financial health of the community. So we want to be good community partners with our vendors as well. So that's 3 key areas that we focus on. With that, let's take a look at vendor and community and employee education. In 2014, when we first started, we were training in our environment, and we really were just responding to requests. If a department called and said, hey, I'd like to talk about cross-cultural communication, or we need to work with our teams, we did training sessions for them. And that's really what we started with. We are so excited because we've seen the progression. If you look at fiscal year 2015 and 2016 and now 17 and 18, you see a consistent move in our expansion of training. And it's training, not for just the sake of training, but it's very strategic. So now in our new team member orientation, we have a program around cultural competency. And its focus is on multi-generations. We focus on the fact that there are 4 generations in the workplace. We prepare new hires that this is exciting, and we're going to learn how to work with all the generations and what those changes mean. So we really start off with looking at some key components of diversity as it relates to orientation. We place it in our foundation and our leadership acceleration programs. We have a program, it's called LAP. Most people are familiar with it. About 15 courses that leaders take as it relates to how do I lead and become an effective leader. But we really focus on diversity and inclusion, leading inclusive teams. How do you retain and develop a workforce when you have many, many different types of people in that workforce? And so that's exciting because our leaders are very equipped for the diversity of our employee base. So we see that as well. But in addition to that, in 2018, I just wanted to highlight, you'll see in the green, we continue to look at some of our developed programs like new team member orientation and LAP, and also responded to requests for team training. But we've also added some real specific training. You'll see in the middle, the blue section is our vendor education. This is the first time that we've actually had vendor education training. And with the vendors, we focus them on how to do business with JPS. It's simply explaining how to encounter, how to go to the website, what's the protocol to do business. So we want to reach out and make sure that we know how to do business with JPS. So we opened up our doors. We had sessions here. We went out to the community. There were some areas where we went to local chambers and said, yes, we want to be able to communicate this information so people know how to work with us in all areas. And that's been really well received. Probably one of the biggest benefits from that, in addition to knowing how to do business with us, is relationships developed in those sessions where we saw some of major prime vendors attend, as well as small businesses. And they talked to each other and talked about collaboration and how can we work better together. And there was just a great appreciation for JPS for opening up and sharing that information. So that's a part of that. Then at the bottom, you'll see around 1,200 people that we've trained as it relates to being in the community and working with all types of programs. For example, Fort Worth ISD was one of the projects that we were asked to participate with, where they had a group of 7th and 8th graders who were interested in all type of careers. We were there representing healthcare, along with other JPS team members, to talk about how do you join the workforce of JPS? What type of careers are there? And it was a very diverse group of obviously 7th and 8th year olds who were very, very pleased to learn about JPS. So we get involved in the community as well, and as we continue to reach out and make sure people are aware. But we're excited about education. It's a big part of our story. We believe it's a driver for what we're seeing with engagement. And we'll talk a little bit about that later, that we're seeing some really high numbers in engagement as it relates to diversity and inclusion here at JPS, and the education pieces are part of that. Yes.
Have you seen the increase in minority diversity vendor that got awarded?
Yeah, very good question. The question was, have we received an increase with minority vendors that have involved? We're going to report on that as well. Yes, we have received an increase, and in two ways. We received an increase in the number of people who've registered to work with us, who are interested, and we've also received an increase in the dollars that we're spending. So we feel like both of those are real strong indicators for us that the education and the outreach is really working.
For the, I guess, there's many categories of vendor that participate. Is there any way you can give us some assessment or some of the struggle that they have to meet the minimum requirement, to see if we can look at long term to see how we can help those vendors? Because
Yes.
sometimes they can't afford to buy certain insurance, or in a bidding process, their price may be higher than regular because they don't have economy of scale. They can't recruit good people unless they pay more. Because not a lot of people want to go work for a smaller company because you don't have a lot. It's a lifestyle, so you don't have options. You don't have other stuff, and that may prevent them from getting a good price to bid. But that doesn't mean they don't give good quality work. So if we're going to invest in that, sometimes we have to pay a little bit more to get to a certain level. So I don't know the answer to that, but it'd be interesting to look at it from that perspective.
Yes, and I think that informally, we're doing a little bit of that. We have one-on-one sessions with vendors where we talk with them about how to do business with us, and things may come up in terms of obstacles that they have. We don't have a formal program right now where we focus on what obstacles they're having and try to help them overcome them at this time. But basically, we do reach out to see what questions are concerned, and then we point them in the direction that they need. I think that's an excellent idea, though, as we look at where we go next and moving forward.
Because what I saw is that young people have a tendency, if they can get to a bigger company, they would jump to a bigger company unless there is something there for them to stay, to build the community and be part of a smaller community employee group. There's a trade-off somewhere along the way, but we need to understand what that is for them to
Yes,
be successful.
very good. Yes. Okay, so what's happening for fiscal year 19? We see that we've done well with 18 with education. Really excited. We're working on improving patient outcomes and the patient experience with a partner, and that's the patient experience team. And we are so excited about working with Laura Burnside and Annika Fisher, just an incredible partnership. And it was put in place by Executive Leadership Task Force, and that task force was comprised of Pia Walker from Human Resources, Laura Burnside, of course, in patient experience, Dr. Duncan in community health, Wanda Peoples in nursing, and Dr. Elliott with our residents. And so we've received feedback on what is needed as we go forth in FY19. So we built a strong foundation of education internally, and the focus this year is going to be, let's look specifically at how we impact our patients. And so training that will be received by our physicians, our nurses, our staff, our staff in the hospitals, our staff in community clinics. What do we need to do to support our staff who have direct patient contact? And so we are really excited about that. And to do that, we've already done the research where we've had benchmarks and we've had brainstorm sessions where we've actually got together several different people from many disciplinaries to say, where do we need to start and where are our issues? As a result of those sessions that we held, we determined there were two key areas, and you see them on the screen. On the left side, you'll see cultural competency education, and that was one of the major pillars. Things like primary dimensions of diversity and disparities, cultural language, cross-cultural communication. We really want to focus on patient culture, beliefs, end-of-life issues. There's so many things, again, with diversity being at the heart of what we do, that this touches, and we're already focusing on multi-generational differences and how to relate to them, not just with employees, but with our patients. And of course, we're looking at all compliance. The Joint Commission has standards as it relates to diversity and inclusion in education, what we do, and we want to always be in compliance, so we're working on educating that area. On the other side, you'll see patient experience. Our patient experience team is going to be working on coordination of care. It was clear in our focus group assessments that training was part of what we could work on, but we had a great opportunity with just coordinating care. What do we do from the time an individual calls us, to what do we do when they walk in the door, to what happens during their stay, and what happens at discharge. And so there's a lot to be worked on in that area. You'll see patient registration, patient adaptability and access. How do we look at EPIC and optimize the features in EPIC to help us identify cultural languages, faith indicators, preferences, all those things that are there for us that we can optimize. And so we're excited about that, as well as discharge. Any questions about just the educational pieces?
Do you know if, this may not be appropriate to ask, does EPIC have multiple languages where the person looking at the screen, but then you can direct to a different languages as opposed to the patient? That way, like when you have a English speaking, writing the script or whatever that is, instruction, but the receiving end is in a different language where it's their native language for them to understand better.
Melinda, the entire room is turning
Yes,
its
I'm
head
going to
towards
say, we're
you.
going to yield to our EPIC experts.
All of his question, but one of it was, I think with one of the, do we have the ability within EPIC that when we are providing information back to the patient that we can do it in multiple languages?
Right, or switch it to, I mean, if we have a user like English speaking, but the instruction needs to be in Spanish, that we can flip it to Spanish for them to use. Do they have that capability yet?
For everything that is information back to the patient, we do. We have a total complete for Spanish, and then a very large percentage for about 12 other languages. And we just purchased, and it'll be implemented in December, a product called HealthWise, and we picked HealthWise for just that reason of its ability to support multiple languages.
So they can search for the disease stage and all that stuff?
Exactly.
Let me make sure I understand that question. If
Put it in
you're on,
English
if you're on your, what is it, chart, the patient chart, and if I'm needed in Spanish, can I switch to Spanish right then, or are you just saying it comes out as an instruction? I'm on the computer, you know how sometimes you can go on a program and it'll ask you which language? Are we able to do that?
You as a user of EPIC, or you as a patient?
Me as a
Those are
patient.
Two different questions. One is the patient side with ChartMax, which is your question.
Mm-hmm.
Your question was more to the provider side and those that use EPIC within inside the system.
Or like
I
e-scribe,
believe.
e-prescribe.
Right. So take those in 2 points.
So, exactly, two things. On the patient side, we have the ability to provide them, which is kind of how I answered his question, but I think it was your question, to the patient, all the information about their visit and what kinds of things they need to do to stay healthy in whatever their preferred language is. We don't have an enormous capability within Epic if we have within Epic the ability to indicate what is the preferred language of that patient. The screens do not change, all the screens are in English.
Okay.
Oh, no, I'm not worried about that.
Yeah.
More instruction for compliance.
Instruction, that's what I thought.
Right.
Okay.
It's called an active visit summary,
Right, it is.
and those come out immediately at the end of the visit, and they'll be in the language of that particular individual.
Do that well.
All right, so let's talk a little bit about engagement. We have the information on employee engagement as it relates to diversity-related questions, and we're happy to report, if you look at FY 2015, FY 16, and FY 17, you will see that we've asked the same questions each year, and they are a statement. I feel JPS Network is a diverse and inclusive work environment, and JPS Health Network values employees from different backgrounds. So we asked those questions on the survey, and we are so excited because every year we've seen a major increase as it relates to where we stand overall in terms of the survey. So on your left, you'll see the overall employee engagement number. For example, is 4.22, and the indicators for diversity and inclusion are both higher, as well as the same with our national averages. And according to Press Ganey, anything that's 0.05 or greater is significant. So you'll see our greatest change in 2017, where we scored 4.55 on JPS Health Network's values employees from different backgrounds. And I believe that is directly attributed to what we're doing from beginning to end as it relates to orientation. We send a real clear message that this is an environment that respects you, values you, and that you're included, and that you make a difference here at JPS. And so we start from the beginning and then throughout. Obviously, there's always areas of opportunity, but we feel real good about the engagement scores and the direction we're going. Okay, questions about engagement? We're good? All right. Our business diversity. DT, you asked a question about business and supplier diversity, and did we see any changes there? Again, we have really good news. As we look at FY16, we were at $14.3 million in spend with our small, historically underutilized businesses. You'll see 17, we're at 16.7, and then that is, by the way, Tier 1 and Tier 2 spend for historically underutilized businesses. What that means is, obviously, we know Tier 1, a direct, where the prime receives the spend, and then Tier 2, that's the subcontractors receiving. We're happy to share today, as we look at year-to-date in 2018, we're at 18.7. That is Tier 1 only. We will not have Tier 2 until after everything's audited. But right now, we know that we're definitely about $2 million more before we finish that. So that's an impressive, consistent gain. And I want to acknowledge the reason we believe we see that gain is through a lot of efforts, and I'm just the voice today, but there are a lot of efforts from people in the room today with our Business Diversity Committee. They have worked tireless. Mason Milewi has led the Business Diversity Committee, and we received strong support from Scott Rule and from Finance and from IT. Really a collaborative effort. The thing that's different is that we're talking to each other on a consistent basis, and there's a tremendous amount of collaboration to make sure that we're capturing this spend data, that we know where it is, and we can report it, and that we have the right information. So good news there as we move forward. Okay?
Is there a possibility to look, I know it's a lot of work to do on your side, but when appropriate, can we see more than just That's what I'm looking for is diversity, but I'm looking for more than the color of your skin, maybe the gender. Also as well, to see how do we help minority, like women in business and all that stuff.
Okay, is there a way to, I want to make sure I understand your question, a way to track what type of businesses are included in
More
that?
like, because I think it's important to have diversity in terms of the color of your skin, but it's also important to see how do we have minority, like women in business and all that stuff.
Okay, when we, that's a good question. So we look at where I say historically underutilized business, Ben, that does include women, that includes small business,
What about
that
veterans?
includes any type of historically underutilized business. So they're all a part of that.
What about veterans or wooded soldiers?
Veterans,
type thing?
yes.
Do you have an ability, Michelle, to break that out? Instead of the larger number, and I don't know that you do or you don't, and it's not a problem if you don't, it's just, do we have the ability to segment underutilized businesses based on women-owned, veteran-owned, and be able to be more granular in that?
Yes, we do have the ability to do that. Part of that would come through the certifications. For example, we have individuals who are certified as a woman-owned business, individuals who are certified as a minority-owned. We know that individuals are certified through veterans. So we can do that. That's not something we've been currently tracking, but we'll be happy to do that and get that information for you.
What I'm looking for is, are we a good citizen of the area that we're in? How much do we reinvest back into our community?
Okay.
When you say small business, do you mean a small business owned by a woman, veteran, whatever else, or is there a small business designation?
Good question. Small business, there is a small business designation, and that has to do with the actual amount of dollars that are spent. There's a cap either with number of dollars that that business entails or the number of employees, and that's it. It's just small business.
Regardless of.
Regardless, it's not.
Gender or
Regardless
race.
of gender, race, it's just a small business. And that is part of what we capture and what we utilize and when those numbers that you see as well.
Okay.
Yeah.
Thank you.
So just quickly, I want to go over a couple wins. It's really a recap. We've talked about this. We think the win that we've had is the streamlining of the historically underutilized business vendor management process in collaboration with the groups I mentioned earlier. We also believe that we're not seeing a fluke, as we will say, with employee engagement. We think that's real, that we are sustaining an environment that people feel valued. We're optimizing our training programs with more than 4,000 individuals reached over that small period of time. And then we were honored by the DFW Minority Business Council for supplier diversity efforts, and we received an award for the JPS lecture series, Preparing Leaders for the Future Workforce and Diversity in the Workforce. Training the prospective vendors, that's new. We continue to work internally and out in the community to establish good relationships with our vendors. And then we implemented the Tier 1 and Tier 2 spend pilot. Before, we were not capturing Tier 2. We just had 1. So now we have a mechanism to do that. So lots of wins there, and we're headed and moving forward. A really simple strategy as we go forward. We're going to drive our strategy to continue to increase the spend. We do take the board's goal that you have placed before us very serious, and so we'll continue to work in that area. We're going to partner with patient experience and all of the executive leaders on the task force in improving patient outcomes and in our area. We want to continue to push the number of vendors who register with us. We believe that if we get people in the pipeline from a lot of different areas, it's going to drive better competition and make more resources available. Partnering with local chambers in the community will continue. And most of all, it's a continuous improvement process. We'll look at best practice, evidence-based, and cultural competency initiatives. So there's going to be consistent research of what's the best way to do this. Innovation, let's be creative in how we do this, and let's make sure we're aligned with the organization's vision and mission. So that's the update for today. I just want to thank you for allowing us time to do this, and thank the board and the executive team and Mr. Early for your leadership and support of diversity and inclusion. We appreciate it. Thank you. Thank
there any questions
Any
before
other
you get
questions?
us?
One comment, evidence-based and best practices.
Glad that you're 50/50. You're
Uh,
almost there.
Well, in some of these, you are actually going to have an empirical best practice that you can tag.
Yep.
The other thing is to compliment Michelle and her team. One of the hardest jobs you can ever have is when it says interim in front of your name, because it is a tough position to be in. And to maintain her staff and maintain their energy and maintain those numbers and the consistency of what we've done speaks to the leadership of Michelle, and it speaks to the willingness of her team to want to put that together. So I applaud you and I applaud the team for doing that. And I applaud the fact that oftentimes I think organizations, and I've seen this, will look outward but not inward. And they will talk about all the diversity efforts they do in the community, but then they look inward and they haven't done anything. And I think you have done a huge amount of work internally, and you've balanced that with external. And that's what will make a big difference, is driving this organization with its 6,500 folks and then reaching out to the community. So I applaud you and your team, and what you all have accomplished in the last year has been pretty phenomenal.
Thank you very much. And I'd like to thank Mason Malawi and Clary Cressy, if you guys would just wave at everybody. They are here today, and say thanks for everything. They're wonderful.
Is
Thank
that
you.
the whole department?
Yes. That's the whole, that is our whole department, by the way. People think there are like 25 of us. There are 3 of us, so thanks.
Not yet. We've got a process.
All right. That's all I have for open session, I do believe.
I learned a new word today.
Huh?
I learned a new word today.
You learned a new word today.
IPO is improvement patient outcome.
Oh, okay.
Yeah.
Oh, okay. So what I'd like to do now is for us to convene in closed session, and we will not be in there long, okay? No, don't say that.
Oh, man.
Can we finish?
That's what I'm gonna do is, I don't even think I had to go into closed session to do it. I just want to give everybody Robert's back.